Today, we're going to talk about ADHD and introduction by Dr. Dalal Elsori, consultant developmental and behavioral pediatrician at KidsHeart.
All right, we'll go ahead and get started. We'll talk about ADHD this morning. I hope everyone can hear me well. Bringing your attention to the fact that it's May, and May is the Mental Health Awareness Month. And so I'm really happy to be giving this talk during the month of May to bring close attention to the importance of mental health, especially over the last few decades where there's been a lot of focus on not just physical health of children, but also mental health. So this is just a quick reminder to all the pediatricians that are on the call today or watching the seminar to please take some time to ask a few questions. And I know your clinics can be very busy and your practices can be very busy, but ask a few questions just to shine a light on how the family is doing or how the children are doing from a mental health standpoint. My mentor always trained me to ask three main questions to any parent or family that comes in. One was about food security, so making sure that this family has enough to eat, because some people will not just voluntarily give you that information. So just making sure you ask. Two is asking about safety within the home. So asking about things like domestic violence, and even if they don't want to share that with you or expose that side of them, then you can let them know to call your clinic or practice anonymously and just let somebody know. But you just provide that sort of support that someone is there for them. And number three is about kind of looking into the mental well-being of the family, parents as well as children. So I know that, again, you guys have very busy clinics. It usually just takes 3 to 4 minutes to ask a few questions. And if you feel that you have picked up on something, then you can either schedule them for a follow-up appointment to ask a little bit more information, or feel free to refer out to a mental health specialist. So that's kind of my introduction here. And then we'll be talking briefly about ADHD, because I feel like if I start talking about ADHD, I wouldn't stop because it's actually a very, very large topic. So I'll just give a brief about what I feel is important from a general pediatric standpoint about ADHD, nothing too detailed. So we're going to give a quick introduction, clinical presentation, diagnosis, and management. So ADHD, or attention deficit hyperactivity disorder. So it's a persistent pattern of inattention and or hyperactivity and impulsivity. So again, there's an important thing that we need to look at here. So the and this is important when it comes to categorizing what type of ADHD subtype it is. And we'll come in just a second. That interferes with daily functioning or development. This is a really important part of the definition of ADHD, because it really needs to be affecting the child's home environment, school environment, academic performance, family life. So something to do with daily functioning is being affected by the symptoms. I apologize. I know my prevalence rates and my statistics are always based on the US, but I've only been here for a few months and I still haven't figured out which source I want to use to get statistics that are reliable in the UAE. If any of you have suggestions, please feel free to suggest. But our most recent numbers for prevalence of ADHD in the US is around 10%, so 9.4%. So that's quite a high number, and it's super, super important to keep in mind. Our rates of mental health disorders, developmental disorders, including ADHD, autism, behavioral disorders, are on the rise. They need to be on the horizon. People need to be screening for them. General pediatricians need to be aware and need to have some form of comfort in addressing these issues, not completely managing, but just approaching families when it comes to mental health disorders. They are on the rise, and you're going to be seeing them a lot more at your clinics. So this is kind of just, it depicts kind of what the numbers of children diagnosed or ever diagnosed with ADHD. So it's clearly on the rise, as we can see, and these numbers are in millions. So it started off with numbers as low as 4.4 million ever being diagnosed with ADHD in the year 2003, up to 5.5 million, 6.4 million in 2011. And then they combined the data from 2016 to 2019 using the National Survey of Children's Health. So that looks at kind of, it surveys children within 11 different states in the US, and it saw that there's about 6 million children being diagnosed per year with ADHD. So that's quite a high number to keep in mind. Also keeping in mind that ADHD, just like any other mental health disorder or developmental disorder, you need to be screening for other comorbid conditions. If you have one, you're at higher risk for developing another. So those with ADHD have a higher risk of developing learning disorders, behavioral disorders. So if you look at this chart right here, there is a 64% chance that the child has a comorbid mental, emotional, or behavioral disorder. Specifically, ODD, oppositional defiant disorder. These kids can have a lot of behavioral problems that we can target with ADHD management. So they can have conduct disorder, ODD, tic disorders or Tourette syndrome, anxiety, depression, and autism spectrum disorder. Just like any other mental health disorder, it puts you at a higher risk for developing one more mental health disorder. So screening for other developmental problems and behavioral problems is very important. I know none of us like, or maybe some of you like detailed pathophysiology. I don't personally, sorry. But this is really important to go over just because it gives us insights into how ADHD medication works. There's two main neurotransmitters to keep in mind that we target when we're talking about ADHD. They're both catecholamines. So the first one is dopamine and the second one is norepinephrine or noradrenaline. Why this is important? So if you look at this little, the graph at the bottom, so the prefrontal cortex is our focus when it comes to ADHD. The neurotransmitters, dopamine, norepinephrine, when they're not as available or they're there at lower levels, that leads to the symptoms of ADHD. So the lack of focus, the hyperactivity. And the reason this is important is because when we use stimulant medication to target ADHD symptoms, what it's essentially doing is increasing dopamine and norepinephrine in the prefrontal cortex with different methods, but they all work on the synaptic junction to increase levels of dopamine and norepinephrine because you get better level of attention. Keeping in mind that also the other end of the graph, if you have too much of the dopamine or the norepinephrine, you're in a state where you're hyper-focused. So that's when your stimulant medication dose is too high. You're hyper-focused, parents will come in and say he's zombie-like. So you really need to be adjusting the dose. You need to find that happy medium where it's not too low of the dopamine and norepinephrine, which is a lot of ADHD symptoms, or too high where you have hyper-focus. So you need that, the sweet spot right in the middle. Little bit of history as well. So I mention this because this is something I've noticed in my practice here in the UAE. I hear a lot of ADD being thrown around. So the term attention deficit disorder. So this is an outdated term. Pediatricians still use it, psychiatrists, psychologists, but I feel that this is a term that really is outdated. It started in the 1980s, the DSM, the Diagnostic Statistical Manual 3 in the 1980s said that, you know, we're going to label this disorder as ADD, attention deficit disorder. And then they said, we're going to do two different types, with hyperactivity and without hyperactivity. So they gave a significant amount of weight to the lack of attention. And then they said on the side, there's a little bit of that hyperactivity, sometimes and sometimes not. In 1987, they revised that criteria and they said, no, we don't think that it's just the lack of attention. We need to give as much focus to lack of attention, so inattention, as we do to hyperactivity. And so the name was changed to ADHD, attention deficit hyperactivity disorder. So we abandoned the term ADD. We went into ADHD, but then the question came about like these kids that are not hyperactive, they only have attention problems. Why are you calling them ADHD? And you still have parents who come in and say, no, this is just ADD. The H factor, the hyperactivity factor scares people. And so in 1994, when the DSM-4 came up, and in 2013, DSM-5, they agreed on a certain criteria. They said it's going to be called ADHD, attention deficit hyperactivity disorder, and three main types. So predominantly inattentive type. So what was previously just ADD is now ADHD, predominantly inattentive type. The other type is ADHD, predominantly hyperactive or impulsive type. And then you have the combined type. So a little bit of both, the inattentive symptoms and the hyperactive symptoms of ADHD. So again, just to go over this, we have abandoned the term ADD. We now use ADHD, and then you can specify what the main features are. Is it the inattentive subtype, or is it the hyperactive impulsive subtype, or is it the combined type? In the DSM-5, the only change they made between the DSM-4 and DSM-5 criteria, they removed the word type and they replaced that with presentation. So they said ADHD predominantly inattentive presentation, ADHD predominantly hyperactive presentation. Reason being is that they started keeping in mind more of kind of the adults under the umbrella of ADHD. So it's not just children that have ADHD, adults can present similarly with ADHD. So it became more inclusive of adults and not just children. So that's just a little bit of background history on kind of what terms are being used, because I still feel like there's a little bit of confusion that comes around, even when it comes to parents or other physicians or pediatricians, we're not too sure which term to use. So maybe just sticking to the most recent criteria, which says ADHD, and then specify what it is. And you need to explain that to families. Like, we don't mean ADHD, the H in there is the main thing. No, we can say it's predominantly inattentive. It's the attention problem that's there. Types of ADHD, just like I talked about, there's 3 main types. So you can either have predominantly inattentive symptoms, and that's usually like the lack of focus, the lack of attention. These kids are usually the disorganized kids. They're easily distractible and they have trouble following directions. They're very, very forgetful. And then you have the other end of the spectrum, which is the predominantly hyperactive or impulsive types. These are the kids that are impatient. They interrupt a lot. And you see this a lot at the clinic. You'll be talking to parents trying to get a history, and the kid is frequently interrupting the conversation. He's always on the go, or you can describe this as the child is driven by a motor. He's excessively active, and he fidgets a lot or squirms in his seat. So he's moving around a lot. And of course, you have the type that's in the middle, the combined type, that combines the inattentive symptoms as well as the hyperactive or impulsive symptoms. The DSM-5 criteria, and the reason I want to go over this, and I know this can get very busy as slide-wise, but when we're diagnosing ADHD, it's really important to keep in mind the DSM-5 criteria. There's so many different ways to screen for ADHD, and it all depends on what your practice was, what your experience was, but you always need to keep in mind the DSM-5 criteria behind what are the main symptoms of ADHD. So when we talk about symptoms, we talked about the portion that's inattention. So we said 2 different portions, inattentive symptoms, and then you have the other portion, which is the hyperactive and impulsive symptoms. So the DSM-5 said that when you want to label a child with inattentive symptoms, you need at least 6. So 6 is key here, out of the 9 inattentive symptoms. And mind you, here it says often. So in the DSM-5, they say it often fails to give close attention, has trouble holding attention, does not seem to listen, does not follow through on instruction. So this is not the kid that every now and then doesn't pay attention. It needs to be the predominating feature that they have. So they often have these features, avoids or dislikes or reluctant to do tasks, loses things to forgetful, easily distracted, and forgetful in daily activities. So you need at least 6 of these symptoms to make that diagnosis of inattentive ADHD, if not combined. We'll get to the hyperactive symptoms. So we said there's inattentive symptoms, and now there's the hyperactive or impulsive symptoms. Again, there's a set of 9 different symptoms, and you need at least 6. And we're talking about childhood here. I'm not talking about 17 years and above, because once you go into the adolescent group and kind of young adults and adults, you only need 5 of those features per the criteria. You don't need 6. But in children, you really do need at least 6 of the 9 criteria. So hyperactive or impulsive type, he fidgets a lot, leaves his seat, runs about or climbs. This can look differently in adults and adolescents. So your preteens, teens, adolescents, they may not be running and climbing, but they're very restless in their seat. They're very fidgety. These are the kids that, you know, have trouble sitting down, or they need to be redirected to sit back down again. But once they do, they're very fidgety in the seat. They're on the go. They talk excessively. They blurt out answers before a question has been completed. They have trouble waiting their turn. So in lines, whether this is at school, at theme parks, out in public, in malls, they have a lot of trouble with that. Interrupting or intruding others' conversations. So these are the 9 hyperactive or impulsive criteria that the DSM-5 came up with. Again, you need at least 6. If your 6 are only hyperactive and impulsive and your scores on inattention are less than 6, then you have the predominantly hyperactive type. If your scores are actually 6 or higher from the inattentive subtype, and then not as much on your hyperactive, then it's predominantly inattentive. If you have a score of 6 or more in both those criteria, you have the combined type. So this is important to keep in mind as kind of the diagnostic criteria. The DSM-5 then went and said that symptoms have to present before the age of 12. So this is a childhood disorder that develops earlier in childhood. So that's why it's really important to take a history and make sure you ask about when these symptoms started. Very, very important as well when making the diagnosis that these symptoms have to be present in 2 or more settings. So what does this mean? ADHD doesn't pick and choose and it just comes up in one setting, which is the home environment or the school environment. There's usually at least 2 settings, which is why when we send teacher report forms and interview forms to get more information, you always need that second setting. So the mom or the dad come in and they fill out a form and they tell you, and they report a lot of the hyperactive or inattentive symptoms. You need to know where the symptoms are being seen. Is it while they're out with friends or relatives? Is it when they're doing other activities and extracurricular activity? Is it at school? Typically it's school and home. So there needs to be a consistency with the symptoms within at least two separate settings. Sometimes I use the clinic itself as a setting to, if I can't get any feedback from the school and I really want to get this child started on treatment, then I will use my clinic setting as the second setting if it's really, really obvious where the child has a lot of trouble sitting down, frequently interrupting, very inattentive. So I'll use that as the second setting. Again, by definition, we need to have evidence that it's interfering and reducing the quality of social, school, or work functioning. And the symptoms are not better explained by any other mental disorder, such as a mood disorder, anxiety, or personality disorder. Just a brief on how to diagnose ADHD in adults. We've already kind of touched upon this, that you don't need as many of the criteria. So you only need 5 of the symptoms mentioned above for inattentive or hyperactive as compared to 6 in childhood. And remember that symptoms might look different at older ages. So irritability, restlessness in your teens and your adolescents, whereas you actually have the full-blown hyperactivity, typical symptoms that you'll see in the younger kids. This is a really nice way that one of the kids describes what it's like to have ADHD. He says, it's like your brain keeps switching between 30 different channels and somebody else has the remote. I think that's really interesting because it just shows how debilitating ADHD can be. So as much as parents will come in and they're very, very frustrated at what they see or what they deal with, imagine what the child is dealing with at this level. So feeling like someone else has control over your thoughts and you really cannot control what you do. And you'll have kids who are verbal, who are older, who tell me, I don't know why I do what I do, but I don't have control over what I do. I have this urge to stand up and move, to wiggle my feet, to wiggle my toes. I need to be out of my seat. I don't know how to sit still. So that's just a very interesting way to look at it. So with regards to diagnosis, so again, the way I was trained was to kind of go by DSM5 criteria and use what we call as a Vanderbilt Form, which I'll show you in just a second, to kind of get feedback from school and parents about whether or not these symptoms from the DSM5 criteria are there. That does not mean that there's not other ways to diagnose ADHD. That's just the way I personally was trained to do it. There's a lot of different screening techniques that psychologists will use, neurologists will use, psychiatrists will use. This is just my personal preference and the way I was trained. So this is what a Vanderbilt Form looks like for those of you that haven't seen one before. It's at the top, it says the Vanderbilt Assessment Scale, Parent Informant. So this is super important to know that whether it's the parent or the teacher that's filling it out. And remember, we said that it has to be in at least 2 different settings. So this is what's nice about this is that you have one that's tailored to parents and you have another one that's tailored to teachers. So the Vanderbilt Form, the parent informant, the first 9 symptoms on the Vanderbilt Form that we ask about, so does not pay attention to details, has difficulty keeping attention to what needs to be done, does not seem to listen when spoken to directly. So these are just your inattentive symptoms. So remember, we had 9 in the DSM-5. These are your 9 that you ask about to the parent. Your next 9 look at your hyperactivity and impulsive symptoms. So things like fidgets in seat, leaves seat when remaining seated is expected, runs about, climbs too much when remaining seated is expected. So those next 9 are your 9 criteria for hyperactivity or impulsivity. The rest of the questions on here are very helpful because they screen for ODD, so comorbid mental problems, your ODD, your anxiety, your depression. And then the last part of this is the performance screen. So if you look at the second part, it's usually the performance screen. So how the parent views that their child is doing academically. Because remember, when we're looking at the definition of ADHD, we want to know if it's affecting quality of life or academic school performance, right? So that's the performance piece of things. And so you score this and you see if they score 6 or higher for the first 18 questions. And there's a specific way to score it after that for the other symptoms, but primarily for the inattentive and hyperactive symptoms. And then you compare this to the teacher informant. So it kind of looks the same, but the only difference is at the top, it says teacher informant. So you get to compare your inattentive and hyperactive symptoms from the school environment with the parents' one. And then score it accordingly, and then you can make the diagnosis. So this is the way I was trained. What's really nice about Vanderbilt forms is they also came up with follow-up forms. So not only do you have your initial diagnosis, but every time that they come in for a follow-up visit, whether or not they're on medication or not, you can ask for follow-up symptoms. So a nice thing about the first, like the top of this page, it says, was he on medication or was he not on medication? What's nice is that if he was on medication, the last part of the follow-up form, you can look for specific side effects, usually of stimulant therapy. So have they had headaches, stomach aches, weight loss, trouble sleeping? But also you can start comparing your scores objectively. So every time a parent comes in, if they're on or off medication, you can figure out if their symptoms are getting worse, staying the same, or are they improving? It's really nice to see improved numbers, especially on the kids that we start on medication. You have more objective evidence. So I'm going to go ahead and switch my screen back to the main presentation. Let's see if this works. Yeah. Okay. Perfect. So we talked about, so Vanderbilt form is the way I typically, or what the method I use to diagnose ADHD. And I feel like it gives me a lot of information about school and home environment. What I've seen others use is Tova testing. I'm not trained to do Tova testing or interpret results of Tova testing just based on the way I was trained. However, our pediatric neurologist here at the clinic does do Tova testing to diagnose ADHD. This is more of a computer-based system. It goes through a bunch of questions over approximately 21 or 22 minutes to assess the child's level of attention. It has a visual part and an audio part, and then you get a score overall, and then that score has a standard deviation that can help you make a diagnosis. Again, I don't use Tova, but I know a lot of people that do, and our neurologist does use Tova, and it is a pretty reliable technique. There are other screeners, of course, just to go back, but for the sake of this presentation, just so we can move forward, I'm not going to go into the details. So when it comes to management options, I get this question a lot from pediatricians as well as parents. What options do we have? We do tend to, as a culture, have a fear of jumping to medication, and I completely understand that. So parents and physicians need to know that we have options. Your options are either behavioral therapy, thanks to our behavioral therapists and all the other therapists, speech and OT that work together. We have behavioral therapy that can target ADHD symptoms. This can be in the form of individual therapy for the child, parent training, so teaching them how to approach their child with ADHD or behavioral problems. Remember, targeting the family as a unit rather than just working on the child is always more effective. Classroom accommodations is a really, really big one. There's not much knowledge and awareness about it in schools here in the Middle East, but it really needs to be well known to teachers and families that there are simple accommodations, and we'll go over those, that you can do within the classroom setting to help children with ADHD, to help them get redirected. So that way we're focusing on the child in the home as well as at school. Medication management, of course, is a big part of what we do for ADHD management, so psychopharmacology. The AAP recommends that for children more than the age, are age 6 years or older, they recommend a combination of behavioral therapy and medication. However, for children younger than the age of 6, and I just want to touch upon the fact that you can make a diagnosis of ADHD as early as 4, so 4 years old. So children less than 6 years of age, behavioral therapy is typically what we start with. Not to say that none of the children between the ages of 4 to 6 have been started on medication. Some of them have, but we choose to try behavioral therapy first as just an isolated form of therapy prior to introducing medication. Those who are 6+, we typically go for the combined approach of behavioral therapy and medication. The other way also is true. So older kids, teens, Their cornerstone of therapy is usually medication plus minus behavioral therapy, but combination therapy is typically superior, but not for the children under the age of 6. Our different types of medications that we use. So this, I feel like, could be a lecture on its own because there's so many different options of medications, and there's so many different practices as well. So I have to give a disclosure that I feel like everybody practices differently when it comes to ADHD management. Different physicians are comfortable with specific medications or experienced with specific medication. There's no right or wrong. Everybody does it differently. The way I personally do it is I was trained that the first line of medication therapy when it comes to ADHD are the stimulant medications. So those groups that are methylphenidate and amphetamine groups that we'll talk about in a second. They work by increasing dopamine and norepinephrine. So we're increasing the neurotransmitters that are deficient. We talked about this at the beginning. They boost the energy, attention, and alertness. They can either be an amphetamine group or a methylphenidate-based drug or medication. They come in a lot of different forms, not many that we have here in the UAE. We have quite a variety in the US, but here we have quite a restricted amount. It could either be a short-acting, immediate acting. It could be an intermediate acting or an extended release drug. So depending on how long it stays in the system, and now we're talking about kind of pharmacodynamics of the drugs, that's how we label it: short-acting, intermediate acting, extended. So short acting means it'll stay in the system around 3 to 5 hours. Typically, I'll say to parents around 4. And that's why usually we dose it twice daily, in the morning and in the afternoon, to cover that entire morning period at school. Intermediate acting lasts a little bit longer, about 8 hours or so. And then you have your extended release that lasts about 12 hours or so. And then you have your non-stimulants. So your non-stimulants are your medications, if you've heard of Strattera, so atomoxetine, or your alpha agonists like guanfacine and clonidine. They are not as effective as stimulant medication. They are definitely not my first line go-to unless there's a severe contraindication to why I don't want to use a stimulant medication. So typically when a child comes to me and they're on atomoxetine or Strattera, my first question is, why? What was the reason that or was there a contraindication to why we started a non-stimulant as compared to a stimulant? And the reason being is because non-stimulants are only 70% as effective as stimulants when it comes to targeting inattention and hyperactive symptoms. Not to say that they're not effective at all, they're just less effective. And they're typically started when kind of there's severe side effects or contraindications. An example I'll give of this is, for example, a comorbid tic disorder or Tourette's disorder. Again, not a contraindication to use stimulant medication, but if you've unmasked tics that are so out of control, affecting the quality of life of the child, and you just can't do stimulants anymore, then you move on to the non-stimulants like atomoxetine or guanfacine. Another reason I use non-stimulants is that sometimes when symptoms are very, very prominent at around the age of 3 or 4, and you don't want to be using stimulant therapy on that age group, then I will start with a non-stimulant like guanfacine just to calm those children down until they're old enough for us to start stimulant medication. Again, I'm going to emphasize the fact that this is my own way of practice. This is the way I was trained, but different physicians have different ways of practicing. So we talked about kind of the 2 different therapies when it comes to stimulant medication. You have your methylphenidate group. So these are things, if you've heard of Ritalin, for example. So Ritalin, which can be a short-acting, or Ritalin long-acting LA, which is the long-acting form. So those are your methylphenidates. And then you have your amphetamine group. And these are things like Adderall, if you've heard of Adderall. Their mechanism of action, just like I said, they increase dopamine and norepinephrine at the level of the synaptic junction. This is just a quick brief into what different medications we have. So within the methylphenidate group, we have Ritalin, Methylin, Focalin, and these are just the short acting. So imagine there's still intermediate acting, there's long acting. So there's a whole world of medication for ADHD. I usually keep the chart in my room to show parents. We don't have that many variety here in the UAE, but know that there are other options outside of the UAE that are being prescribed. So it's nice to be aware of that. Amphetamines like Adderall is one of the most kind of common amphetamines that you see. Our non-stimulant therapies, you'll see, are your selective norepinephrine reuptake inhibitors. So these are things like atomoxetine, which is the brand name is Strattera, or alpha adrenergic agonists. So these are things like clonidine and guanfacine. They last longer within the system. They're not as effective as stimulant medication, but they are used in specific cases. Contraindications to stimulant therapy. So when do you not use stimulant therapy or recommend stimulant therapy? Children who are also taking monoamine oxidase inhibitors, those with glaucoma, hyperthyroidism, medication sensitivity, so anaphylaxis or severe sensitivity reaction or allergic reaction to the medication, overt cardiovascular disease, and I underline this a million times, it needs to be overt cardiovascular. So you need to be asking a good history about the child's cardiac history of if they've had congenital heart disease, if they have a history of sudden death in any previous family members, or a cardiac history in people and within the family of less than 40 years old, sudden drowning cases within the family that could be cardiac linked. So taking a good cardiac history, because typically there is no need to get a baseline EKG before stimulant therapy. We'll get to that in just a second. Active psychosis, substance abuse, and uncontrolled hypertension are also contraindicated. There's not too many contraindications. I would say most of the kids do qualify to start stimulant therapy because these are kind of the rarer cases. I want to just go over the classroom accommodations. So this is a busy slide, I apologize, but simple classroom accommodations, which is what we talked about. So things like getting extra time on tests, instructions and assignments that are tailored to the child. So if you can break down the task for the child to do, positive reinforcement and feedback, allowing breaks or like a movement break. So those kids that feel like they're squirming or fidgeting in their seat, you can even apply tape around the child's seat or desk to let them know that they can stand up, they can wiggle around, squirm around within that area, and then sit back down. So have that movement break. Extra help with staying organized. So remembering that maybe the teacher can just pass by and make sure that the child is staying on task or understands the task that's on hand, or they're doing it the correct way, they haven't misunderstood it. Making sure assignments are not long and repetitive. Shorter assignments are always better. Allowing breaks, using organizational tools like folders, involving the school counselor and psychologist. So working as a team and collaborating between school parents and healthcare providers is always essential. Parenting strategies for children with ADHD, it can be very frustrating to parents, and it can cause a lot of tension between the parent and child dynamic within the home. So just reminding parents to provide a lot of positive attention. So remember, ignoring negative behaviors and focusing on the positive behaviors is always good on the long term. Giving effective instructions. So if you're telling the child, today you're going to do your laundry, then you're going to pack your bag, you're going to go to school, he probably stopped listening at today and didn't listen to anything else you're saying. It would be very important to kind of use visual aids if you want to write it down on a board, if you want to use pictures, note cards, something more visual that they can check off, kind of like a list, like, okay, I finished cleaning my room. The next thing she asked me to do was to pack my school bag. So you have a list that's visual for them to follow, because they're probably not listening if you're just saying it, that this is what we're going to do today, 1, 2, 3, 4. Praise your child's effort. Praise is something very easy to do, but families sometimes forget to do. Praise the positive, praise the child's efforts whenever they're trying. They may not show it immediately, but it is on a developmental level really a healthy thing to do for your child. They end up knowing how to praise themselves and having more self-confidence themselves when they do positive behaviors. Establishing a reward system, be it a reward chart or promising the child something that they really, really want at the end of a good week. But you need to put your goals, you set your objectives and your goals so that you're both on the same page. A really big one I find that we culturally struggle with is the use of consistent consequences. Reason being is because we tend to have larger extended families in the Middle East. We have grandma, grandpa, aunts, uncles, everyone kind of involved, sometimes living in the same home. It's really important to have consistent consequences, meaning if you do A, you're gonna get B. And then if for example, the child does not do their homework, you're gonna take the iPad away. Mom says that, then dad comes along and says, no, that's fine. Here, stay on your iPad. The child knows that he or she will get her way with a certain member of the family, or mom and dad are on the same page and say, you don't get the iPad after you don't do that specific amount of work. Grandma comes along and says, no, haram, gives the iPad. So this is another issue that we have. So we need to provide consistency with boundaries and consequences within the home and setting limits. Other interventions with limited evidence. So again, limited evidence, and I don't say it's ineffective. There's just not enough evidence, and there needs to be more studies and more research. Physical activity is a big one. Physical activity is healthy for everybody, every child. With the American Academy of Pediatrics, outside of developmental pediatrics, they always recommend at least 60 minutes of moderate to vigorous activity per day for children just to stay healthy. It improves overall cardiovascular health, psychosocial well-being, and cognitive performance. Things like yoga, team sports, aerobic activities, and walks can get that energy out of the child with ADHD. They've seen that it improves the core ADHD symptoms with little risk of harm. But additional studies need to be done with regards to what type of exercises, for how long exactly, and to be in details, but physical activity is healthy for everybody. Dietary interventions, these are a big hot topic. I'm not going to get into it in details because I could go on forever about it, but there needs to be a lot more studies about elimination diets. So parents will come in and swear by the fact that they eliminated a certain preservative or additive from the food and the child got better. Not to say that there've been a few randomized control trials and meta-analyses that have shown that yes, when they remove specific preservative or additives, the child does seem to focus a little bit more, but these results were not consistent, and the studies are too small to generalize to the general population. The way I look at it, I say if you're following a specific diet, well and good, make sure that there's no nutritional deficiencies, and preferably follow with a dietitian or a nutritionist so we make sure that the child is getting all the adequate nutrition that they need. But I don't oppose families unless it's a harmful diet for the child. I'll go ahead with it as long as there's a nutritionist on board. A newer thing they came up with was essential fatty acid supplementation. This goes with kind of the theory that people came up with that noticed decreased fatty acid concentrations in the serum of children with ADHD. So they saw that supplementing with fatty acids can help with core ADHD symptoms. But again, these meta-analyses and randomized trials have conflicting results, and there's no clear evidence just yet. This is a huge one. And this is one that they ask about in exams. So this is something I know that is a huge, huge hot topic, probably a hotter topic than diet, video game-based intervention. Because there's so much going on nowadays with social media, gaming, kids being on iPhones, iPads, tablets, they've tried to kind of find a way to make these modes efficient in kind of treating and managing ADHD. So it said these kids are on their computers all the time. Why don't we do something useful and trying to target their ADHD? In 2020, the FDA approved the first game that they said was helpful with ADHD symptoms, this Endeavor RX. I've never played it personally. I've never prescribed it personally. There's very limited evidence about it. You do need a prescription to get it, and it's for children between the ages of 8 and 12 with primarily inattentive symptoms or combined symptoms. It's intended to be used with other ADHD treatment modalities. So this is really important. You don't neglect other treatment modalities that are evidence-based, such as behavioral therapy and medication therapy, and go for just kind of these alternative methods. I'm open usually to hearing about them, and I learn a lot from my patients, and I try to keep up to date with research. But have I ever personally prescribed this? No. I have heard parents who have enrolled their children in these kind of programs, and they do see some improvement. Is it clinically significant? I'm not too sure. So we still need a lot of evidence. Another one is this new trigeminal nerve stimulation. Again, I have personally never tried it. This is still under clinical trials. It's a neuromodulation technique, and it goes kind of with the hypothesis that electrical stimulation of the trigeminal nerve affects the areas of the brain thought to be involved in ADHD. Whether or not it works, we're not sure. What's the safety of it? Still, it needs a lot more studies. I don't prescribe it personally, and I don't know any patients that have tried this, but I do hear about it kind of from other areas outside of Abu Dhabi. Common misconceptions. I wanted to touch upon this really quickly, and I think we have just a couple more minutes. I hear this a lot kind of from not just parents, but I see this in pediatric reports as well. Stimulant medication is contraindicated in children with tic disorders. So absolutely not. I know it can be scary when you start seeing tics in a child. So tics are involuntary movements. When you start seeing them in children that you start on stimulant therapy, it's been shown that stimulant therapy can unmask or uncover an underlying tic disorder. So this child already has a baseline tendency or risk to develop a tic disorder, and your stimulant therapy unmasked it. It's not uncommon to see tics. I always tell parents not to panic. You'll see shoulder shrugging, blinking. It happens. As long as it's not interfering with quality of life, I don't treat it. I don't touch it. If we're getting good ADHD symptom control and there's a little bit of tics on the side, I don't treat the tics and I don't change the medication. However, if it's severe tics that you've unmasked, then you need to alter probably your medication, your dosing, maybe switching to a non-stimulant, as well as possibly treating the tics, but it's absolutely not a contraindication. Another one I've heard is that when a child has epilepsy or seizure disorder, stimulant medication is contraindicated in children with seizure disorder. This is false. I have a lot of kids who do have epilepsy who also have stimulant medication because they have ADHD. So remember, there is a higher rate of epilepsy and seizure disorders in kids with baseline ADHD and vice versa. And so our first line therapy is always stimulant medication, and I still follow that with the kids with epilepsy. However, if it's poorly controlled seizures, poorly controlled epilepsy, you can get a neurology consult just to make sure you're cleared from that standpoint before starting your stimulant medication. If it's well-controlled epilepsy and you're comfortable with that, then go ahead and prescribe the stimulant medication. There were studies that kind of proposed maybe lowering the seizure threshold. The stimulant medication lowered the seizure threshold, but this was found to be not clinically significant. So it's still our first line is to use stimulant medication for kids with ADHD and seizures. In conclusion, ADHD can be diagnosed as early as the age of 4. Screening for comorbid developmental issues and learning disabilities is vital in children with ADHD. This is very important. Management options include behavioral therapy as well as medication, usually both, but depending on the age of the child, we can decide which kind of path we want to take. And one more thing that's not on here, I just want to say that these kids need close follow-up. There's a reason why we bring them back every month if they're on medication. These medications do have side effects. I haven't gone over them in this lecture. Main one being appetite suppression. Sometimes there's sleep disturbance, irritability, sensitivity, tearfulness. So they do come with their own side effect profile. So they need to be monitored closely, be it with a developmental pediatrician, a general pediatrician who's comfortable with ADHD management, pediatric neurology, child psychiatry, and so forth. So in general, if you feel that you're one of the general pediatricians who is comfortable treating ADHD, that's totally fine to start a stimulant medication. But if you don't, then you do have specialists out in the community who can help. All that's being asked of general pediatricians is to screen and see if there's any concern from parents in order to refer. And thank you very much. I'll take any questions. I don't know if we have time for questions, actually. No, we do.